Hey everyone, welcome to Pharmacology Chapter 24, Anti-Inflammatories. So this chapter is going to explain how inflammation happens and how drugs reduce it. So today we're going to learn how the body creates inflammation and how the medications interrupt that process. And if you understand the pathway, then you'll understand why drugs work and why they cause side effects. So for a quick NCLEX tip, understanding the pathway is going to help you predict GI bleeding, kidney injury, bleeding risk, and fluid retention. So here's the critical point. When we give anti-inflammatory drugs, we reduce symptoms, but we also reduce normal protective functions, such as stomach lining protection, kidney blood flow, immune response, and that's why side effects happen. Inflammation occurs due to trauma, surgery, infection, temperature extremes, or chemical exposure. When inflammation begins, the body releases chemical mediators that create the signs and symptoms that we see at the bedside. Histamine is released from mast cells and causes vasodilation and increased capillary permeability. This explains the redness, the warmth, and the swelling at the injury site. Kinins are responsible for pain and swelling. They stimulate nerve endings, which is why inflamed tissue feels tender and throbbing. The prostaglandins are produced at the site of injury and are key players in pain, fever, and inflammation, and they also sensitize pain receptors, making discomfort worse, and they help regulate important protective functions like stomach lining protection, kidney blood flow, and platelet formation. Most anti-inflammatory drugs like NSAIDs work by blocking prostaglandin production. That reduces fever and pain, but it also explains side effects such as GI bleeding, kidney injury, and bleeding risk. So remember, inflammation causes symptoms, but the mediators causing those symptoms also serve as protective roles as well. Okay, so let's talk about the inflammatory phases and the COX enzymes. Very important. Inflammation happens in stages, and medications target specific parts of this process. So we're going to talk about the stages or the phases. So the vascular phase is the first response to injury, and it begins within 10 to 15 minutes. So blood vessels widen, become more permeable, allow fluid and immune components to move into the injured tissue, and this increases blood flow, causes redness and warmth, and then also leaky fluid leads to the swelling. In the delayed or cellular phase, this occurs after the vascular response and involves white blood cells migrating to the site of injury. So these little leukocytes or white blood cells work to destroy the pathogens, clean up the tissue, but their activity releases chemicals that cause ongoing pain and prolonged inflammation. So that's why inflammation that lasts too long can become damaging instead of helpful. Now, COX enzymes, this is something you really want to get nailed down, so we're going to go over it more than one time. COX enzymes are responsible for prostaglandin production, but they have very different jobs, and we're going to differentiate their jobs. COX enzymes convert arachidonic acid into prostaglandins, which cause pain, swelling, fever, and redness. So there's COX-1 and COX-2. COX-1 protects stomach lining and supports platelet function. COX-2 produces pain, fever, and inflammation. So when COX-1 is blocked, what's at risk? Okay, so if COX-1 protects the stomach lining and supports platelet function, then you may see gastric bleeding, renal injury, or platelet inhibition or increased bleeding risk. So real briefly on this slide, just the cardinal signs of inflammation, as you should know very well, is redness, swelling, heat, pain, and sometimes loss of function. Anti-inflammatory agents or anti-inflammatory drug groups reduce pain, but they do it differently, and that matters very much clinically. So it's important to understand the difference. So some major groups of these anti-inflammatory drug classes. First of all, NSAIDs, they're usually the first line for pain and inflammation. Corticosteroids are powerful systemic inflammation control. DMARDs slow disease progression, but they're not pain medications. And anti-gout drugs target uric acid or inflammatory response. So going back to the NSAIDs, the key actions is to inhibit prostaglandin synthesis, reduce pain, fever, and swelling, and inhibit platelet aggregation. NSAIDs work by blocking the COX enzyme, which the body needs to make prostaglandins, and since prostaglandins cause pain, fever, and inflammation, and platelet activation, blocking them reduces those effects. So some important information about this is inhibits prostaglandin production, so less chemical signaling for pain and inflammation, relieves pain, nerve endings are less sensitized, reduces fever, so the hypothalamus is no more being told to raise body temperature. It inhibits platelet aggregation, so there's less thromboxane, and that increases bleeding risk. And they mimic corticosteroids, but they're weaker. They reduce inflammation, but they do not suppress the immune system like steroids do. So NSAIDs are grouped based on what chemical family they belong to and which COX enzyme they block. All NSAIDs reduce inflammation. The difference is how specific they are. So COX enzyme reminder is COX-1 protects stomach and helps platelets clot. COX-2 causes pain and inflammation. And you're going to hear this over and over throughout this presentation. So first generation NSAIDs are like aspirin, ibuprofen, and naproxen, and so they block COX-1 and COX-2. First generation NSAIDs are not picky, they block both. And what that means is they're good for pain and inflammation relief, but there's more stomach irritation and more bleeding risk. Makes sense. Second generation NSAIDs are the selective COX-2, and an example of that is Celebrex, and that's the only medication I found that is just COX-2 specific. And what they block, COX-2, mostly spare COX-1. They mainly focus on COX-2, like I said, and the enzyme responsible for pain and inflammation. Now what this means basically is there's less stomach irritation, there's less bleeding, but they are a higher risk for cardiovascular risk like myocardial infarction and stroke. So let's go back over it again. I felt like I was a little tongue-tied there. First generation NSAIDs is like a master key, opens all the doors. Look at it like that. COX-2 selective NSAIDs are like a targeted key and only opens the pain door, and that's it. But blocking COX-2 alone can throw off the body's clotting balance, so that puts patients at increased risk for cardiovascular issues. So why COX-2 selective drugs increase the cardiovascular risk? Well, COX-1 helps platelets clot properly, and COX-2 helps balance blood vessels. So when we block only COX-2, we reduce inflammation, but we may increase the risk of clot formation. So less stomach bleeding, more risk of heart attack and stroke. So basically, I'm going to sum this up. NSAIDs are grouped by which COX enzyme they block. First generation NSAIDs block both COX-1 and COX-2, so they relieve pain, but also increase the risk of stomach irritation and bleeding. Second generation NSAIDs are more selective for COX-2, which reduces stomach side effects, but that selectivity can increase cardiovascular risk. So when choosing an NSAID, we always weigh GI risk versus heart risk. Salicylates, aspirin. We're going to talk about aspirin actions. Aspirin actions are anti-inflammatory. They inhibit COX-2, decreasing the prostaglandins. Antipyretic, lowers fever. Aspirin is antiplatelet. irreversible for the lifespan of the platelet. The platelet lasts lifespan 7 to 10 days, which is what makes aspirin useful in preventing heart attacks and strokes, but also explains increased bleeding risk. The body continuously is making new platelets, so clotting ability is reduced, but it's not removed. So if a patient has GI upset with aspirin, the MD may prescribe an enteric-coated aspirin instead. Some toxicity alerts. Serum level greater than 300 mics per ml is toxic, so you want to watch for tinnitus as an early sign. That's ringing in the ears. So if a patient complains of that, you want to make sure you hold the aspirin and call the MD. Confusion, hyperventilation is also a toxicity alert. Some drug interactions to discuss. Warfarin increases bleeding when it's combined with aspirin, so due to platelet inhibition and increased bleeding risk, you may want to note that one for NCLEX purposes. Uric acid, low dose aspirin can reduce uric acid excretion, and ACE inhibitors, aspirin can decrease their antihypertensive effect. Also, on the screen, increased bleeding with anticoagulants and other NSAIDs. Risk for hypoglycemia with oral antidiabetics, increased gastric ulcer risk with glucocorticoids. Aspirin can decrease cholesterol. It has an anti-inflammatory effect on the vascular system, and it can decrease T3 and T4 as aspirin alters the protein binding of thyroid hormones. It can decrease potassium. Some food interactions, salicylates in foods that naturally have it is prunes, raisins, licorice, spices like curry and paprika. Dietary salicylates don't replace aspirin, but they can enhance its effects, so it's important, especially in bleeding risk. So you never want to give aspirin to children with a viral illness. Rye syndrome can result in liver failure and encephalopathy. Aspirin is effective, but it's not harmless. These cautions exist because of how aspirin affects platelets, prostaglandins, and developing organs. You don't ever want to take aspirins with other NSAIDs. They shouldn't be combined with things like ibuprofen or naproxen, and this matters because it increases the risk for GI bleeding. It can increase the risk of renal injury, and actually there's no added benefit for pain relief if you try to combine the two. They need to be avoided during the last trimester of pregnancy because it can increase the risk of maternal and fetal bleeding and can delay labor. Do not give to children with flu or virus symptoms, as we mentioned in the last slide, as it may lead to Rye syndrome. And just to go over quickly a few side effects, aspirin, some adverse side effects, reactions is dizziness, lethargy, headache, confusion, agitation, diaphoresis, dehydration, GI stress, ulceration, bleeding, seizures, tinnitus, hearing loss, and Rye syndrome. And you want to always stop an aspirin stop before surgery 7 days and avoid alcohol. If a patient reports ringing in their ears, what would you do? You would hold the medication and notify the provider. So again, I know this may sound repetitive, but we're trying to reinforce inflammation is the body's protective response to injury, infection, or irritation, but when it's in excessive amounts, it causes pain and tissue damage. So some key signs of inflammation, again, redness, swelling, heat, and pain. So recognize cues. So what is the nurse going to look for? So first of all, determine the patient's medical history. So history tells us why inflammation might be happening. So we want to ask about their chronic conditions. Do they have a history of arthritis, gout, any kind of autoimmune disease? A recent injury or surgery? Kidney or GI disease, that's going to be real important for medication choice. So we would obtain a drug history. Medications can cause, worsen, or treat inflammation. So include prescription medications, NSAIDs, steroids, DMARDs, over-the-counter meds. Sometimes people don't consider over-the-counter as that they should put that on their med list, and they fail to mention it, but it's real important, as you can see, if they're taking something like ibuprofen or aspirin. Herbal supplements like garlic, turmeric, and ginkgo. Never assume that over-the-counter means safe, because it's not always safe. Analyze cues and prioritize hypothesis. Now we decide what the patient's main problem is. So based on cues, likely priorities include acute pain, inflammatory injury, or nausea. Often can be medication related. So some nursing actions, interventions should reduce inflammation while protecting the patient from side effects. So some examples of that would be administer anti-inflammatory meds as ordered, monitor for GI upset, bleeding, edema, use non-pharmacological measures, rest, ice, elevation, and educate patient on medication safety and follow-up. So what does success look like? We know our plan's working when inflammation improves. So an expected outcome would be swelling and redness decrease within a week, pain's reduced, patient tolerates medication without complications. Effective inflammation management requires recognizing the cues, identifying the cause, selecting safe interventions, and evaluating patient response. Again, may sound a little bit repetitive, but take action. Monitor the serum salicylate level. Observe the patient for evidence of bleeding. Advise patient not to take aspirin with alcohol or warfarin to prevent increased bleeding. Instruct the patient to discontinue aspirin approximately 7 days before surgery to reduce risk of bleeding. Take action continued. Warn parents not to give aspirin for virus or flu symptoms to children to avoid risk of the Rye syndrome. Educate patients to call the Poison Control Center immediately if a child has taken a large or unknown amount of aspirin. Inform patient that aspirin tablets can cause GI distress. Parachlorobenzoic acid, or diclofenac, work by inhibiting both COX-1 and COX-2, which decreases prostaglandin production. So what is this drug doing? By blocking the COX-1 and the COX-2, reduce prostaglandins that cause pain and inflammation, but it also reduces prostaglandins that protect the stomach and the kidneys. That is why these medications work well and why they come with risk. So why does patients get these drugs? These medications are commonly used in inflammatory joint conditions like rheumatoid arthritis and osteoarthritis. These are conditions where inflammation is driving the pain. So what to watch for? Neurologically, dizziness and headache related to the prostaglandin changes in the central nervous system. GI effects like nausea and vomiting, constipation from reduced gastric protection, that COX-1 inhibition. Fluid and electrolyte effects, sodium and water retention, hypernatremia, hyperkalemia. Prostaglandins help regulate renal blood flow, so when we block them, fluid and electrolyte balance can be affected. So some nursing implications: use cautiously in patients with heart failure, hypertension, and kidney disease, and monitor their blood pressure, their electrolytes, and signs of fluid retention. The parachlorobenzoic acid, NSAIDs, provides strong anti-inflammatory relief by blocking COX-1 and COX-2, but their effects on the GI tract and kidneys require careful monitoring. Ibuprofen, the most widely used NSAID there is. It inhibits COX-1 and COX-2 by blocking the arachidonic binding, and it's used for pain, osteoarthritis, and rheumatoid arthritis. Side effects are drowsiness, dizziness, headache, confusion, insomnia, dreams, blurred vision, tinnitus, gastric distress, and bleeding and edema. Some drug interactions: increased bleeding with warfarin, increased effects with fentanyl, sulfamides, warfarin, and decreased effect with aspirin. Ibuprofen continued. Recognize cues. Obtain a drug and herbal history and report any possible drug interactions or herb-drug interactions. Assess for GI distress and peripheral edema, which are common side effects of NSAIDs. Analyze cues and prioritize hypothesis. Acute pain, injury, nausea. Generate solutions, as we talked about earlier. Clinical judgment. Ibuprofen continued. Take action. Observe the patient for bleeding gums, petechiae, ecchymosis, or black tarry stool. And because NSAIDs affect platelets and the GI lining, the nursing care focuses heavily on early detection of bleeding and patient education. So to report if the patient has GI discomfort, advise patient to avoid alcohol when taking NSAIDs, alert patient that many complementary and alternative therapies may interact with NSAIDs and could cause bleeding. These are early warning signs of bleeding. Oxycams, meloxicam, or other name for that is Mobic. It decreases prostaglandin synthesis by inhibiting COX-1 and COX-2. It's used in osteoarthritis and rheumatoid arthritis. Some side effects or adverse effects is dizziness, headache, GI distress, bleeding, edema, but it is usually well tolerated, and well tolerated doesn't necessarily mean it's risk-free. It just means that patients experience fewer side effects at the therapeutic doses. By favoring COX-2, meloxicam targets inflammation and pain while causing less GI irritation than non-selective NSAIDs, though the GI risk is still not eliminated. Meloxicam is a COX-2 preferential NSAID used for chronic arthritis pain that provides effective inflammation control with a somewhat improved GI safety profile compared to older NSAIDs. I know this is getting a little bit repetitive, but again, side effects include dizziness, headache, sinusitis, GI distress, ulceration, obstruction, perforation, peripheral edema, hypertension. And then NSAIDs in older adults, drug interactions are more common due to the number of drugs that they take. So a greater incidence of GI distress, ulceration can occur. Reduced dose decreases the risk of the side effects, however. They need to increase their fluid for adequate hydration as well. Corticosteroids, prednisone and dexamethasone. Steroids shut down inflammation at multiple points, which is powerful but dangerous. NSAIDs turn down the volume on inflammation, but corticosteroids turn off the whole sound system. So why do we use steroids? Steroids are best for short-term control of severe inflammation. Some common uses are arthritic flare-ups, acute inflammatory conditions, severe swelling or pain that's not controlled by NSAIDs. When inflammation is intense and fast relief is needed, steroids work quickly and powerfully. The reason they're not the drug of choice for chronic arthritis is because what makes steroids powerful also makes them dangerous with long-term use. So some major risks with prolonged steroid therapy include immunosuppression, which that increases risk for infection, hyperglycemia, hypertension, osteoporosis, GI ulcers, and adrenal suppression. So steroids trade fast relief for long-term consequences, and that's why they're used short-term. They're used at the lowest effective dose and transition back to NSAIDs, and then your patients transition back to NSAIDs or other therapies. So we taper steroids and never stop them abruptly. Corticosteroids suppress the adrenal glands, and so if you stop them abruptly, It can cause adrenal insufficiency, hypotension, fatigue, and even shock. So the typical taper is about 5 to 10 days, depending on the dose or the duration. Okay, now let's talk about DMARDs. That stands for disease-modifying anti-rheumatic drugs. DMARDs don't just treat symptoms, they change the course of the disease. And the key difference from NSAIDs is NSAIDs symptom relief only. Corticosteroids are short-term inflammation control, but DMARDs work slower, but they protect the joints and the organs long-term. Some different types of DMARDs we're going to talk about. Immunosuppressive agents. These drugs reduce an overactive immune response that is attacking the body's own tissues. Methotrexate, if you've ever heard of that medication, that falls under this category, and it's used when inflammation is immune-driven. Okay, so immunomodulators, they don't just shut the immune system off, they calm and redirect it. Less blunt than steroids, but better for long-term control. The next one is anti-malarials. Some drugs originally used for malaria were found to reduce immune-related inflammation. So some examples students may see later is the hydrochloroquine. It has a slower onset and fewer side effects. Again, methotrexate is the first-line DMARD for many inflammatory autoimmune diseases because it's effective, it's well-studied, and it can slow disease progression. So if you want to remember one DMARD, methotrexate's a good one to remember. Why we prescribe the DMARDs? For refractory rheumatoid arthritis. And then when NSAIDs and steroids aren't enough, DMARDs are needed to stop the joint destruction. Osteoarthritis, spondylitis, especially when inflammation is severe or progressive, and this helps preserve their mobility. I apologize, I got cut off on the last slide, but also wanted to mention DMARDs reduce immune-driven inflammation in the gut in Crohn's disease and ulcerative colitis. Now for this slide, side effects, adverse effects, here we go, headache, fever, influenza, oral ulcerations, pharyngitis, sinusitis, GI distress, infection, hypertension, hypercholesteremia, and injection site reaction. Immunosuppressive agents, action and use. Some patients with rheumatoid arthritis need stronger medications when NSAIDs and methotrexate don't work. And these drugs are called biologic immunosuppressants like TNF blockers and interleukin-1 inhibitors. They work by blocking specific inflammatory chemicals that cause joint damage. By turning those signals off, they reduce pain, swelling, and it slows the disease progression. Because they suppress part of the immune system, they increase the risk of serious infection, obviously. So that's why patients must be screened for TB before they start taking these drugs. These medications are long-term treatments, not cures. If the drug is stopped, the symptoms will usually return. So some key nursing priorities, teach patients to watch for signs of infection, reinforce that TB screening has to be done before therapy starts, emphasize really good hand hygiene and infection prevention, and remind patients not to stop the medication abruptly. These biological therapies are an escalation in treatment. They are used only when first-line therapies fail because of their risk and cost. These medications are very expensive, so this will be, I don't want to say last resort, but sort of last resort. So TNF inhibitors and interleukin-1 blockers are reserved for moderate to severe rheumatoid arthritis due to infection risk and immune suppression. Immunomodulators, biologic immunomodulators. Some diseases happen because the immune system is too loud and keeps attacking the body. These medicines quiet the immune system. So again, two simple types. Type 1 interleukin-1 blockers, and these drugs block one inflammation signal called interleukin-1. Interleukin-1 message is the message that tells the body to inflame joints and tissues, and blocking it results in less swelling and damage. Type 2, the TNF blockers, these drugs block a strong inflammation signal called TNF. They're major troublemakers in autoimmune disease. Blocking it calms inflammation. So a memory trick is TNF, terrible nasty fire, you want to block it. So what these drugs do, they stop inflammation before it causes damage, slows disease down, protects joints and organs. They do not just cover pain, they prevent harm. So why we use them in diseases where immune system attacks the body. Like in rheumatoid arthritis and those that you see on the screen. Antimalarials. Some drugs originally used to treat malaria are also used to treat or control autoimmune diseases like rheumatoid arthritis and lupus, and we use them for refractory rheumatoid arthritis that helps with long-term disease control. And they do not work fast. They work steadily over time, so patients won't feel better right away. The effect takes about 4 to 12 weeks. So the patients must keep taking the drug even if they don't feel improvement. Stopping too soon is the most common reason that these drugs fail. We don't know the exact mechanism, but we know they calm the immune system. They reduce immune overactivity, decrease inflammation over time, and they protect the joints and tissues. In nursing, we don't always need the exact pathway. We just need to know the effect. Chloroquine is some specific safety points is absorbed well from the GI tract. It has a very long half-life. It stays in the body for a long time, but it accumulates in the liver. And why this matters is patients with liver disease or heavy alcohol use are at higher risk for toxicity. Some absolute contraindications, allergies to chloroquine, pre-existing eye disease. Why? Because there's a risk of retinal toxicity, so vision damage can be permanent. They do need regular eye exams, baseline and ongoing. Gout pathophysiology. Inflammatory disease of joints, tendons, and other tissues, and it usually occurs in the great toe. Defect in purine metabolism leads to uric acid accumulation. Purine containing foods such as organ meats, sardines, salmon, gravy, herring, liver, soups, and alcohol, especially beer, is high risk for gout. It's caused by too much uric acid in the body, and it shows up again, like I said, in the big toe. The body either makes too much uric acid or can't get rid of it well. Uric acid comes from the breakdown of purines. And we just talked about the certain foods that it contains purines. Uric acid forms sharp crystals that settle in the joints, and that's why gout hurts so bad. It doesn't dissolve well, and these crystals trigger intense inflammation. Other problems uric acid can cause is kidney stones. Colchicine is used to treat acute gout attack by calming inflammation and not by fixing the uric acid level. So colchicine stops the white blood cells from rushing to the joint. It prevents neutrophil activation. It blocks white blood cell movement to the joint, like I just said. That reduces the swelling, the redness, and the severe pain. So no white blood cells, less inflammation. So what colchicine does not do, it does not lower the risk of uric acid. It does not stop the uric acid production. It does not help remove it. It only treats the inflammation of the attack. So it's used for acute episodes of gout attacks. And so it works best when it's started very early. It's well absorbed in the GI tract, works quickly within a few hours. It's mostly eliminated in feces and excreted in the urine. Renal problems increase with toxicity risk, so increased fluids, of course. Major side effect is GI upset. That's the biggest one in the colchicine. And about 75% of patients experience GI symptoms with this drug. So diarrhea is the warning sign that the dose may be too high. And always take with food to reduce the irritation. Allopurinol prevents gout attacks by lowering uric acid levels. It does not treat an acute gout flare. So you see the difference in those two drugs. Colchicine treats the attack. Allopurinol prevents future attacks. So how allopurinol works, it blocks the enzyme and that makes uric acid. It inhibits that xanthine oxidase. This stops xanthine from being turned into uric acid, and the results are less uric acid in the blood. So if you don't make as much uric acid, then the crystals can't form. Allopurinol is used for long-term gout prevention, especially helpful in patients with chronic gout, kidney disease, uric acid, kidney stones, blood disorders like leukemia, polycythemia, poor response to other gout drugs. This one works better. This is the drug of choice for chronic gout. Some important teaching: allopurinol should not be started during an acute gout attack. Why? Because it can worsen or prolong the flare. Start allopurinol only after the acute attack resolves. Patients should increase their fluid because that's going to promote uric acid secretion, help to prevent kidney stones, alkalinizes the urine, and reduces crystal formation. Water helps wash uric acid out. So what it does not do, it does not treat pain, it does not reduce acute inflammation, and does not work immediately. So this is prevention, not rescue. So to wrap up allopurinol, it's a xanthine oxidase inhibitor used for long-term prevention of gout by reducing uric acid production. So we want to monitor the renal function, encourage fluids, assess pain meds. And why does increased fluid intake matter with allopurinol? Because that will help prevent kidney stones and enhance the uric acid excretion. So clinical judgment: allopurinol, take action, record urine output, monitor lab tests for renal and hepatic function, instruct patient to increase fluid intake to increase drug and uric acid excretion, advise patient to have a yearly eye exam as visual changes can result from prolonged use of allopurinol. This has been a lot to cover for these medications. Go back and listen to it as many times as you want. I apologize for struggling through some of these, but I hope you will get what you need out of it and ask questions if you have them later in class. Thank you.